Good evening, everybody. Welcome to Peer-to-Peer Academy. I am joined by my colleague, coworker, good friend, Dr. John Vukich. Together, we practice in Milwaukee, so I'm sure we've got some people in Milwaukee joining us. This is going to be a unique experience tonight. So what we're doing, and we've done webinars. I mean, Dr. Vukich, you and I have done webinars and talks, dozens of talks, and I mean, a lot of talks over the years. This is the first one that we're going to do together for patients, specifically for patients. And this is meant to be very interactive. So we want people to ask questions. There's a chat button at the bottom of the screen. Go ahead and type questions in there. We're going to answer them as they come in. Now, disclaimer, as we talk about things, we're talking about cataract surgery. We're talking about specifically the light adjustable lens, why we like it, how we've done it, specific questions that you might have. This is not providing medical advice. This is just a resource to you. And any specific questions that you might have, I would definitely encourage you to talk to your eye care team. But we're hopefully here to provide a little bit of a resource. So, Dr. Vukich, hey, thanks for joining us and welcome.
Thanks, Nick. Thanks, Dr. Bruns. So this is actually, I think, just a great forum to discuss what are the options in eye care for individuals who are looking at the need for cataract surgery. There are choices now that didn't exist maybe a generation ago, where we just simply do our best to, replace the lens that we had to remove, but glasses were the expectation. And now we have the ability to really reset the visual system to make a quality of vision, to provide quality vision that, actually may be the best that someone may have seen in memory. Someone's always needed glasses. Now the cataracts have made the vision even worse, and we can take the power that is necessary in the glasses, put it into the implant, adjust the implant, and come up with a very high quality outcome. So it's an exciting time to be in eye care. It's an exciting time to be able to provide this amazing opportunity, quality of life enhancement for patients. And that's what makes what we do so much fun.
Yeah. So today's talk is going to be all the FAQs. I mean, you and I hear different frequently asked questions from patients 20 times a week, specifically about the light adjustable lens. So let's start at the top. The most common FAQ that I hear from patients is the light adjustable lens is a monofocal lens. So what makes this different compared to any other lens that we have available?
Okay, so boy, where do we start with that one?
Yeah.
It is fundamentally different. So with a standard lens, and these are the ones that insurance covers, that Medicare covers, we get one power of lens, and we'll try to match it to what the patient needs, but it doesn't correct astigmatism. It comes close in many cases, but absolutely is not fine-tuned to what the patient needs. We're getting in the ballpark. It is a single vision lens. Now, the light adjustable lens, we can take and adjust it so that essentially we're making a prescriptive correction on the implant, but it's more than just that. So we're not just making glasses, if you will, on the implant so that we're fine tuning the vision. It also has a depth of focus quality that provides intermediate and reasonably good near vision as well. And so what we have is a blend of vision that allows individuals to have intermediate vision, that's dashboard, that's computer screen, the ability to see their watch, their phone. Now, if you're going to be looking at something really tiny, if for someone who's tying a fishing line, or maybe someone who's working on jewelry or something, yeah, there may still be the need for very thin, very low power reading glasses. But for 95% of someone's day, maybe more, it provides a functional level of quality of vision that is extremely high. So it is not accurate to say it's a single vision lens. It has the ability to be adjusted to give individuals the focus and the quality of vision that they want, and the ability to try it on for size. I mean, that is remarkable. Previous generations of IOLs, and we put them in, IOLs being an intraocular lens, we put them in and we get what we get. I mean, there
Mhm.
isn't really any chance to go back, and we fine tune with glasses. With this, we get a very good quality of vision, but from there, we fine tune. From there, we are able to essentially make the quality of vision consistent with what the health of the eye would allow. So if you have a good tear film, if you have a normal cornea, if you have a healthy retina, we're going to get 20/20 vision, in many cases, even better. And so just a profound and fundamental difference. And Nick, I'd love to hear your take on when someone asks that question, how do you explain it?
Well, I mean, you hit all the big things. Calling it just a monofocal lens is like calling the Mona Lisa just a painting. It's much more than that, right? And for people who want to go through cataract surgery, we have to separate cataract surgery out from your need from glasses. Cataract surgery by itself is just fixing the cataract. It doesn't have anything to do with your glasses. We try to be as accurate as we can with a traditional procedure, but there's a lot of variables and a lot of math that goes in. And the biggest variable of them all is quite simply every patient's individual healing process. Everybody's different. We think that we're pretty good. However, there is this unknown. How is the patient going to heal and what's going to happen? So the light adjustable lens gives us the chance to nail it. It's like golfing. I always use this as an analogy. With our standard traditional procedure, we're just trying to get the ball on the green. And that's a pretty darn good shot. And if you're like me, if you're not in the woods, that's a great shot. I'm happy. But with the light adjustable lens, we get the chance to putt the ball 3 times. And like putting, you have to wait for the ball to come to a rest. So we putt, see where we're at, putt it again, see where we're at, and get it eventually in the hole. Now, if we have a high demand for range of vision, we can do that, which is really cool. The laws of physics still exist, though. So I think it's really important. And you and I think we have this conversation all the time. Setting realistic expectations is essential, and we can't bend the laws of physics. So I look at it like this. You've got a spectrum of vision. On one end, you've got high distance demand, like trying to land a plane in the rain at nighttime. Really high distance demand. And on the other end of the spectrum, you've got tying those fishing hooks, sewing, knitting, reading, paperback book in the dark, high near demand. I want you to be most of your day in the middle where you don't need glasses. And that's really our goal. Now, if we skew one way versus the other, you may need glasses for that other side of the spectrum. But most of your day, we hope that you don't need glasses. And we can tailor it to exactly what your lifestyle. So if you are flying planes at night in the rain, that's for you. Great. Let's prioritize that part of your vision. If you do a lot of reading, let's prioritize that. But you can test drive it in real time. And that's really, really what we love about it. So let's go to our second question. Now, with the process, I'm assuming a lot of people on here know the process. We do 3 adjustments followed by 2 mandatory lock-ins. And the lock-ins are where we're really setting that lens and making sure that it doesn't optically change. There's added protection to the lens called active shield. Can you explain what that is and why lock-ins are even necessary with the active shield?
Okay. So excellent question. So the FDA recommends, and in fact, on the label says that we need to protect the lens, the light adjustable lens, from ambient ultraviolet light, and that patients are instructed to wear UV protective glasses. So that is something that is in the label, but we also have on the lens itself, we have a second line of protection. Now, the active shield is something that gets turned on or turned off. It protects against UV ambient light from influencing the lens until it's finalized and locked in. The coating that does that, however, is not permanent. It lasts 6 months, maybe a little longer, but it provides that level of protection, but it's not indefinite. So we do need to have a lock-in, even with even with the protective shield. So that is think of it as, a safety device that allows someone like I've had patients who said, well, I walked out to get my mail today and it was sunny and have I made a serious mistake? It's like, no, you haven't. You're going to be just fine. And yes, it isn't on the label, but the reality is, you don't need to wear the UV protective glasses at night. You don't need to wear them indoors. And even if there's windows in your house, that just simply hasn't been a problem, and it isn't a problem. Now, again, that's medical advice. It is not what the FDA label says. But we use the same light adjustable lens that is used in Mexico, it's used in Canada, it's used all of Europe, and many practices around the world don't even give out the UV protective glasses. They don't even provide them. It's just like, you don't need them. Don't worry about it. It's not a deal. So we're not saying that because we're following the FDA, rules with some common sense adjustments. So does the active shield protect? Absolutely. Does it last forever? No, it was never meant to, but it does provide that level of experience and safety.
Yeah, well put. I mean, it is a redundant coating. It's like wearing your seatbelt. But just because you wear your seatbelt, if you get in a bunch of car crashes, is that going to keep you alive all the time? No, it's a seatbelt. It's there to protect you. The active shield does wear off over time, and it is dose dependent too. So for us in Milwaukee, I mean, the sun shines like 4 hours a day in December. So the sun's not it's not that intense. Now,
Not
if
a
you're down in
problem.
the
Yeah.
Caribbean, maybe 4 hours a day. But if you're in the Caribbean on a sailboat, that's a different story. I wouldn't want you walking around. And yeah, we get patients all the time, and I think patients are a little bit more sensitive to the instructions, and we appreciate that. I never would argue with somebody being overprotective, but the reality is, yeah, if you go out and get the mail and you don't have your glasses on, did you do damage? No, the lens is totally fine. Now, if you live, for a year and you don't wear the glasses, that's a different story. So the answer to the question, the lock-ins definitely are necessary. The active shield will wear off over time. How long does that take? I don't know. Do you know how long it takes? We don't really know that. I don't want to find out though. So yes, the active shield does a protection, but it does still mean that you have to have a lock-in. Perfect. So let's go to the next question. This one we hear all the time. You as a surgeon, you've dealt with really hard patients before, really hard eyeballs. Probably some of the most notoriously difficult eyeballs are ones that have had RK. Can you talk about RK patients? Can you explain what RK is, first of all, and then talk about why this is a or is not a good option?
So 25, almost 30 years ago, was just the beginning of the revolution in corrective eye surgery. The ability to have someone who was nearsighted be adjusted in a way that gives them good normal distance vision. It was called radial keratotomy. It was a procedure that was actually imported from Russia and refined and made much better in the United States. And it was the first step towards being able to recontour the front of the eye in a way that provided neutralization of the refractive error. Now, we got better at it. We decided that, okay, this works really well, but we can do the same thing with a laser and even more accurately. And that's when LASIK came into play. And this has been over 20 years now that LASIK has supplanted radial keratotomy, but many, many patients did have RK to begin with. And of course, literally millions of patients have had LASIK. And so what that does is it recontours the shape of the cornea. But what it doesn't do is it doesn't eliminate time. I mean, every year we're a year older and, gray hair, wrinkles, and cataracts. And if you had radial keratotomy when you were 45, 30 years ago, the math is against you. You will develop cataracts and there'll be a shift in your prescription. But what it also means is that the shape of your cornea, the shape of the clear part of the front of the eye, has been altered. And our nomograms, the things that we use to predict lens power, are really all situated and they're all designed for corneas that have not had that alteration. Plus, the alterations will have nuanced differences in where the effective power is. And what it does is it just creates, as a long-winded way of saying, it creates uncertainty in the selection of an implant, meaning that we'll do our best math, but at the end of the day, we can't be confident we're going to have exactly what we want or what we intended because the cornea isn't necessarily predictable in how it acts. That's where the adjustable implant, the light adjustable implant, it's a game changer. We don't have to have, it's not like one shot and you're done. Now we can get close, but we can also then adjust and fine tune in a situation where we weren't able to be as accurate because of pre-existing previous corneal surgery. We can now do a great job. And the same is true with LASIK, that we now have the ability to fine tune. And so it just completely changes the conversation and the expectation for someone who understood and had clear vision without glasses because they had RK 30 years ago or they had LASIK 25 years ago. And they really know the personal quality of life value for that, which is real. But now it's slipped away. Well, it didn't wear off. The LASIK didn't stop working. they develop cataracts. And that is where the treatment now needs to be centered. And now we know we can do the same thing. We can do a premium cataract operation. We can do a custom procedure, and that custom procedure comes with, expectations, obviously, quality of life considerations, but it's also high tech, high touch, and it's a journey that we take with the patient, and it costs more. I mean, that's the reality of it. It's a personal judgment that people will make and say, all right, well, what is it worth to me to have that quality of vision? And if it's within the realm of possibility, is it something nice I can do for myself that I'll enjoy? And it's durable. So, again, a long-winded discussion or maybe concept of corneal stability and refractive error correction. But the light adjustable lens, boy, it just is a game changer.
Yeah. That's the easiest conversation I think for me to have when I have somebody who's had RK and they're considering upgrade options. You can always do the standard. You can always do the traditional lens. That is always on the table. The expectation there, though, again, is probably glasses. We'll do our best to keep you as low of a prescription as possible. But the reality, especially with RK, expect glasses for both distance and for reading. I tell patients all the time, just expect to get a bifocal or a progressive lens after. And if we don't end up that way, that means our math perfectly worked out. Great, but it doesn't always happen that way. RK is difficult. It is a challenge that we have to deal with surgically, you do, and then me post-operatively. But the light adjustable lens really is a no-brainer in those patients. I mean, when I see somebody who's had RK, I always talk to them, hey, this is the best option for you. Because what can happen with RK is the cornea can be a little bit unstable. As you heal, that healing process, that's the big variable in our math problem here. We usually do have to extend that out a little bit. So for the average individual, we do our light treatments starting at about 3 weeks. And that's when the average person with a cornea that hasn't been touched before is pretty refractively stable. And then we can start making our putts, right? For RK, we have to push that out. We don't start the adjustments for at least 4 to 5 weeks, and oftentimes I'll bring them back several times to make sure that they have stability. Just like putting, you got to make sure that ball comes to a rest. You can't putt the ball while it's still moving. If the cornea is still shifting, if it's still not perfectly stable, I only get 3 shots. We only have 3 shots to make an adjustment. We want to make sure that we're getting repeatable data points. And it does mean that the process does extend out a little bit. So on average for those individuals, it's probably 2 to 3 months, give or take. But they tend to be the happiest ones. All of our patients with the light adjustable, and not all of them, but most of them tend to be very, very happy. The RK patients understand what that fluctuation tends to be because they've had that procedure done and they really shine with this. The other part that RK patients really do well on is that the cornea almost acts like a multifocal contact. So if anybody in the audience has had multifocal contacts, the way those work is optically splitting light. So your cornea has, in essence, with RK, it's kind of splitting light a little bit and it provides an element of depth of focus. So you can have really good distance vision and actually some reading ability too without any sort of compromise. So it does work fairly well. So for those patients, especially those with RK, I mean, would you ever do a multifocal or a depth of focus lens, Dr. Vukic?
There's no way. There's no way. If you did that, there would be a very high potential chance that this patient would be unhappy. I mean, you can't do that with the same level of confidence, and so I would not recommend that. A good way to take care of the conversation and take care of patients is, what would I do for my wife? What would I do for my children or myself? And the answer needs to be consistent. And what would I do for myself if I had had RK? I would never use a multifocal. I would only consider using a light adjustable lens. And so the advice that we give always should be applicable. Turn it around and say, what would you do with your vision? And you can't go wrong. That is simply it's just the level of experience that we have, and the opportunity to understand the nuanced decisions of how to get the best quality of vision isn't something we could expect patients to make that decision. They don't want to be an optical expert.
Mhm.
They want to get advice, not confusion. And so that, from a professional standpoint, is I want to know what's the best, and just give that to me as a recommendation.
Yeah, the upside is clearly the precision. The downside is the time. And
Yeah.
when we started doing this, 5 years ago, I
Yeah.
remember thinking that people weren't going to like the time, the amount of time
Yeah.
that it took, right? On average, it's 6 to 8 weeks for for a normal case. I find that people really don't mind the time. And in fact, a lot of people want to extend that time out because it's like test driving your car for a couple extra weeks. Wouldn't it be nice to just, yeah, I'm taking the car up to the mountains for the weekend. Maybe can I test drive it before I commit to it? Make sure it handles well in the snow, make sure it handles well in certain conditions. That is literally what you're doing when you're going through this adjustment process. You are literally test driving your vision in different scenarios. We started doing this our first couple of months doing it. I think we were doing adjustments on Monday and Thursday. So we had 3 days in between each adjustment. And we found that, that wasn't enough time. I got the comment on the question all the time. I'm going up to the lake or I'm going golfing this week and I don't really want to make a decision on my next appointment because I haven't done those activities and that's what I like to do. So we found that 3 weeks was almost not long enough, or 3 days was almost not long enough. And we extended it out to at least a week. And even still, I have patients who want 2 to 3 weeks. That is fine. As long as you're following the instructions, if you've got eye drops that you should be taking, take the eye drops. You should be wearing the UV glasses outdoors. Make sure that you are, you can't move away. That's the big thing. I can't have patients moving away. I mean, because you have to come back. But time is really on our side. And I say our as the patient, as part of that team, on our side, because we're waiting for your visual system to adapt. We're waiting for your eye to continue to heal. And that's no different for RK patients. But multifocal lenses, yeah, I agree with you. I'd be a little bit nervous about putting a multifocal lens in somebody who's had RK. And refractive surgery, you just have to be careful. Even LASIK, specifically hyperopic LASIK patients who were farsighted before LASIK. But that's a different question. So,
You know,
yeah,
Nick, I'd love to discuss a question that I get all the time. So
sure.
there's two versions of the light adjustable lens. There's the LAL, and then there's the LAL plus.
Hmm.
And I've had patients say, well, obviously I want the plus. That sounds better. I mean, it sounds like the limited edition or whatever it is that makes it, the Grand Caravan. I want the grand part.
Of course.
But it's a bit of a misnomer. So I'd love to kind of discuss a little bit about what decisions go into or what factors go into the decision about which lens to choose and how, in fact, the plus isn't really a plus. It's an option for some patients that is maybe a good choice or a better choice, but is definitely an option where the regular LAL or the standard LAL is in fact the much better choice. So let's kind of dive into that a little bit.
Yeah. Good question. So I almost wish that they had named it something different,
Oh,
LALA versus LALB, right? They are more alike than they are similar. They're both fantastic lenses. They both have the same qualities and characteristics that we have known to, appreciate with the light adjustable lens, and that it can be adjusted 3 times. We have the same amount of range. The only real difference is a subtle change in design with the LAL Plus. You mentioned before that the LAL is not simply a monofocal lens. It's a monofocal lens with a certain degree of asphericity. And asphericity, it sounds like a bad thing, but it's really a good thing. What it does is it provides just a little bit of depth of focus, and that aids in our ability to keep the eyes teamworked together while providing a little range of vision up close. So the LAL plus, at least theoretically, is a little bit more aspheric, which means that it provides a little bit more depth of focus. And so what we find in clinical practice when we do a target, we're sacrificing one eye just a little bit at distance to give it more up close. We call that blended vision. Think of it like monovision. A lot of people have probably had monovision where one contact is set for distance, one contact is set for reading. This is like that, not as extreme. And we preserve binocularity and depth perception that way. So the LAL Plus, we find that we don't have to separate the two eyes out by as much. It provides a very comfortable binocular version of vision with really good reading. Now, if we have that lens, why wouldn't we just use that for everybody? Of course, it's like the iPhone 17. If you're going to get an iPhone, get the latest one, of course. The reason we don't use it for everybody is because every eye is just a little bit different. If we have a lens that's a little more aspheric, we need to make sure that our corneas are pristine. We need to make sure that, patients who have had prior refractive surgery, their corneas have been permanently altered. We want corneas in our clinic, at least based on our judgment, that have not had surgery. people with severe dry eye, people who might have macular degeneration or glaucoma, anything that might compromise your vision even just a little bit, we don't find that we need to really make that jump because in those cases, the LAL works just fine and it provides as good of a visual outcome as the LAL Plus in those scenarios without any risk for things like glare or halos or contrast loss. Not that that's a common thing, but again, in surgery, we're trying to control every single variable that we can. And this is just one variable that we control. Typically, I mean, John, I don't know, we don't really talk about it to patients a whole lot. We just kind of say you're a candidate for X or Y and we go that route, right?
Well, it comes back to like make the recommendation that you know will provide the best quality of care. Now, of course, there's Dr. Google, right, or Dr. Perplexity. I mean, but patients, and we expect that. And patients who are looking at this and they're making an informed decision, at least by looking up what's out on the internet and what's available. And so patients will come in saying, "Well, there's two different choices. What is the? Why are you choosing one versus the other?" So it's a conversation that comes up if we're asked, but quite honestly, what we want to do is provide the best quality of care. We want to provide the best quality of vision. It makes for a very happy patient. It provides what are patients asking for? They don't want an LAL plus. They don't want, what they want to
Mhm.
see better. I mean, it's just so fundamental. Let's not get, too tied up with the nomenclature of what it's called, but let's talk about what is the vision that you want to achieve. And that's at the end of the day, that's really all people care about.
Right. It's the outcome. And so we definitely I don't shy away from those questions when somebody asks me about
Yeah.
it because I think we have very good reasons. They cost the same. There's no difference in anything. It's just me as the physician, us as the physicians, we want to make sure that you as the patient are set up for success. We have no incentive to leave anybody dissatisfied. I mean, that just creates headaches for us. We want to have everybody as happy as possible. If we think that we can achieve the best result with the LAL instead of the LAL plus, that's the route that we're going to take. And we get questions all the time on it, which is totally fine. And I think we have a very good answer for why we would do one over the other. But it does come down to specific anatomy and specific physiology. It comes down to your specific eye, the way it's built, the way it's designed. And if you have specific questions, I definitely would encourage you to ask your doctor about why maybe. There was a question that came in about a scenario where somebody was implanted with the LAL, but was curious about the LAL plus. There's probably a specific reason why the LAL was chosen, not the LAL plus, and it may come down to just your own physician's experience. Dr. Vukich, is there any difference in surgery between the LAL and the LAL plus?
Zero. We can't even tell which one it is. I mean, you can't tell just by looking
Yeah.
which lens it is. So they handle identically. They're used identically from a surgical standpoint and from a patient perspective standpoint. They are completely interchangeable. You cannot tell the difference.
Yeah, the only way that I know is the serial number.
Yeah,
It's just a one
exactly right.
digit change in the serial number,
Yeah.
but otherwise you would really have no idea. You can't tell. We even look at our aberrometers. An aberrometer is a way to measure high order optical qualities, and there's really not a whole lot different that you can tell based on the numbers. Again, it's just one added variable. If we can control every variable, we're going to take advantage of that. There's just one extra variable. You mentioned one thing earlier, and this is kind of the elephant in the room with any premium surgery, the cost. It costs extra. Can you talk about why does it cost so much? Why does this LAL specifically cost so much? Why doesn't insurance cover it?
For the same reason insurance doesn't cover LASIK and they don't cover RK, they don't cover, I mean, it's, you know, if a patient expresses the desire to have the best possible quality of vision and be free of glasses, the insurance companies are saying that's a good idea. You should do that, but we're not
Yeah.
going to pay for it. And the reality is that everyone, if somebody else paid for it, everyone would choose a premium lens. Everyone would choose the lead adjustable lens because it is that much better. Now, why does it cost more? Well, it's like with anything in medicine these days, this is high tech. The materials and the development costs for the lens were significant. This was, over 10 years in the development of using this space age material to develop a lens. There was a significant amount of cost to develop this and bring it to the market. And at the end of the day, you have to kind of put it in perspective as well. I had a patient say not too long ago, I had a dental implant and a crown, and it was actually just about the same, maybe a little bit more than my light adjustable lens. It was like, well, okay, what is the value of a tooth? Well, that patient didn't want to wear dentures. That's fair. Okay. Did insurance pay for the implant and the crown? No, that was an out-of-pocket cost, but that was a choice they made because it's a quality of life issue. They wanted to have, the ability to chew in a more natural way. Okay, well, you only have two eyes, you've got 32 teeth. What is the value of having high quality vision that allows you to see very, very well every waking moment, every day for the rest of your life? Well, that's a question I can't answer for someone. If it's within means, many people would say, wow, this is I want that. And almost inevitably, after it's all said and done, patients said, I would have paid more for this. This is amazing. It's changed my life. Yeah, it was a decision and I had to think about it, but at the end of the day, it was like the best thing I ever did.
Yeah, yeah, I mean, you look through your eyes every waking moment of your days, and it's putting a dollar amount on a cent. It's a lifestyle choice, right? It is a lifestyle choice. And for people who really value spectacle independence or freedom from contact, this is a once in a lifetime opportunity. You know, you have an opportunity to make your vision better. Also have an opportunity to get out of or stay out of glasses. And it really comes down to that lifestyle, you know, for active individuals, for people who are, you know, just for any reason, I suppose, just want to get out of glasses. I mean, we have people of all shapes and sizes who want that freedom, and this is what we can deliver. So I want to take this opportunity to talk a little bit about the science. Let's get nerdy here for just a little bit and talk about what makes this lens different. Now, another reason that it costs so much, I mean, that machine that we use to do the adjustments costs, it's six figures. It costs that much. And if you've ever seen it, it looks pretty basic from the outside, but if you take off the cover and you see the number of wires and lenses that are in there, it is intense. It's something that I don't like to be too close to because I don't want to sneeze on it and break it. It is an intense piece of equipment. Now, what that machine does though, it's applying a very particular pattern of UV light onto the lens. So the lens is actually made of silicone. And embedded in the silicone are macromers, these little molecules. These molecules are formulated in a way that they are activated by the UV light and they bind together. So what happens when the macromers and the molecules bind, they create a concentration gradient. And then the free-floating macromers will migrate, just like salt in water. It's properties of diffusion and osmosis, really. It's not osmosis, there's no water involved, but diffusion. So these free-floating macromers will migrate and the lens will swell. And it's so predictable that we can create micrometer shifts in the shape of the lens to match a glasses prescription. So that process starts at about 12 hours after an adjustment. So when somebody comes down, they sit in the chair, and I have a little lens that we use to hold their lids open. I'm applying a very particular pattern on that lens. Now, once we have that lens in a shape that we need it to be, the final stage is that lock-in. And the lock-in is where we're applying a broad beam onto the lens itself. We're applying UV light to every remaining molecule in that lens, and that's what causes the lens to freeze up. Anything to add on how it works? I think that was pretty,
Yeah, no,
yeah.
I love the wonky part. So I'm gonna maybe just take it up just a little bit higher altitude and say, all right, well, so when you get a pair of glasses, so you sit behind this device called the phoropter, and the doctor will say better one, better two, and then you try to choose what you like. You say, I want to see it again. Okay, better two, better three, and they'll come up with the best solution for your correction. And it's a set of numbers. There will be numbers that they can write out. And those numbers then can be sent to a very, very high quality grinding system that will make glasses. That's how your glasses are made. Those numbers provide the ability to mill a set of glasses that go into the frames of your eye, on your bridge of your nose, and that's what focuses the light. What this does is it takes those same numbers, it's the refraction that would have or could have been used to make glasses, and now it takes this extremely high-tech deformable mirror. literally hundreds of thousands of little micro lenslets, micro mirror reflective surfaces that take the wavefront, that take the shape that would have been translated to make glasses, and it creates a level of illumination that is variable in the exact prescriptive correction to shine onto the implant. Think of it as you're now milling a new prescription onto the implant. You're taking and you're making glasses on the implant. And the translation of the molecules in the implant, it's literally molecule by molecule. So we're talking about nanometer differences in the shape to provide this optical surface. It is space age. And that is it's the time we live in. Smaller, faster, better, high tech, higher quality. We live in this time that is remarkable in terms of what healthcare can provide. And this is, I think, maybe just one of the best examples of how we can change someone's life in a very positive way using technology. Um, the individual who actually have the patent and developed this polymer that is deformable with UV light, they won the Nobel Prize. This is
Hmm.
a Stanford scientist. I mean, this is material science that is worthy of a Nobel Prize. And we are fortunate enough to be able to use this for quality of life changes in people.
Yeah, I mean, this is probably, we've been doing implants and cataract surgery since 1946. So,
Yeah,
really in the realm of medicine, that's not that long. This is probably the biggest advancement that we've had, at least in my career for sure. I mean, I don't know about your career, but probably the biggest advancement in the history of ophthalmology and lens implant surgery.
yeah,
I want to take a moment to real quick remind everybody that we are taking questions live, and we actually just had a question come in. So please put questions in the chat box. We're kind of rolling as we go here. We don't have any specific itinerary. We're reading questions live here. Should it be routine practice to perform a YAG capsulotomy prior to lock-in? Can you explain what a YAG is and then why we might do it? And should we be doing it during the light treatment process?
sure. Okay, so YAG it's an abbreviation. It's yttrium aluminum garnet laser, and
Say
what
that
it
10 times
does.
fast.
Yeah, exactly. But a YAG laser. So what it does is, so when we put the implant in an eye, any type of implant, doesn't matter if it's light adjustable or not, any implant, we intentionally leave a very thin, clear membrane in the front of the eye that holds the implant. It's why the implant doesn't require stitches. It's held in place by its fit, and its fit is on this clear membrane. But it's living tissue, and over some period of time, that living tissue will start to lose its transparency. Typically within, as little as a year, sometimes as little as a few months, and usually within 3 to 5 years, virtually everyone requires a laser touch-up. And I describe it as saying, well, if you have curtains on your window, you don't tear the curtains down, you simply pull them apart. And so you pull the curtains across, and now you can see out the window. Well, it's the same thing with the egg laser. We don't remove that tissue that was clear and is now a little cloudy. We just move it to the side. So the question that was asked is, should we be doing that earlier in the process before we do a lock-in? And the answer is typically not, and for a couple of reasons. One is that during the healing process, that tissue, that clear capsule, is a barrier for some of the normal healing components that can cause swelling. And so we don't want there to be a free flow of those components into the back of the eye. That tissue creates that barrier, which makes it less likely for that to occur. Secondly, we want the implant to heal into place. I mean, there is some process by which the implant then becomes more firmly locked into place so that it can't and won't and will not move. And we want that process to continue. So the answer is we do the egg laser when we need to, not before. And I wouldn't do it prior to the lock-in. And so that is kind of the standard right now. Now, are there times when we do it before? Absolutely. There are types of cataracts that are very, very dense, that have fibrotic plaques. And that sounds bad, and it is actually. It means that we can't clear that membrane. We can't make a clear path. We can still put the implant in, but we know that there's this this area that's going to influence the vision. And we will do a laser ahead of the lock-in in those situations. That's the exception, not the rule.
Yeah, nothing comes without risk with doing a YAG or any medical procedure. So I usually tell patients when they ask about it, because a lot of times people are doing their research and they know that a YAG capsulotomy is something that may need to be done. Um, I tell them that let's not do it until we need to do it. So there are points though in certain individuals where getting the refraction, when I ask you which is better, one or two, two or three, we do that test. If I can't get good responses from you, it's not because you're not good at doing that test. It's because you can't see them, and because you're looking through almost like a wax paper membrane, and that's when a YAG is something that we might need to do. So generally, we don't usually recommend it. Now, there are physicians that do, and there's different philosophies with this. I don't want to step on anybody's toes if they are doing it, or if you are a patient that had that done. It's not necessarily a bad thing. There's different ways to do things. But generally, we don't, because nothing comes without risk. We like to leave options on the table if we need to. Which kind of brings me to a point here, a question that just came through. After the surgery, eyesight's improved. Is there anything that somebody can expect to go through? Or let's say hypothetically, vision changes after the lock-in. Any thoughts on that? Why might that happen? Why might somebody not have a good outcome, or at least a good perceived outcome?
Well, okay, so the visual system is complicated. There's no question that it's a wonder of biology that we can see as well as we see. One of the most important refractive surfaces, except for the lens, obviously, is the front surface of the cornea. It's the tear film quality that is absolutely essential. So if you have dry eyes, if you don't have that layer of moisture that smooths out all of the natural micro little divots and things that are in the cornea. It's living tissue. It's not perfectly smooth, but yet when the tear film is adequate, it smooths out the surface. It creates a high gloss surface, if you will, and it creates an optically good quality. Well, as we mature, I mean, we dry out, okay? End of the day, people get dry mouths, and it's in our eyes. We don't produce the same tears like we did when we were kids. And the reality is that we can supplement with tears. We can supplement with dry eye medications, and there's different ways to really not only not only add back to the tears that you aren't making or enough of, but preserving the tears you do make, or having other ways in which we can treat. And Nick, you work with this all the time. I kind of love to hear your take on what are the choices, and why would people even need that?
Yeah, I mean, dry eye is the biggest thing. Why might somebody have an outcome that is less than ideal? I mean, dry eye for sure. I want to start by saying that if you read any study, if you look at any trial, any FDA data, nothing is 100%. Nothing. We're trying to slim those margins down as much as we can. So compare the LAL to a monofocal lens. If you look at the percentage of time that we get within a half diopter. A half diopter is pretty much the smallest contact lens that we would ever use. With a monofocal lens or even a multifocal lens, that's about 60 to 70%, give or take, depending on which study you look at. The LAL in our own numbers are about 95%, 92 to 95%, depending on the study. Our own numbers are closer to 95 within that half diopter. It's not 100. So there are variables, there are things that can change. One of those things being prior RK, prior LASIK, corneas that are aberrated. Remember what's happening. If you have a cornea that might be subtly irregular, just the way you're designed, your lens may be a shape, your natural lens before we remove it, it may be a shape that masks that irregularity. Now, when we take that lens out, we put in a new lens, it's like stacking lenses together. Your cornea, your lens, they work together as functional components of any camera. So you're stacking those lenses together. There can be subtle irregularities there. Now, it's not the light adjustable lens that's the problem in that case. It's the fact that your cornea may have irregularities, and any lens that we would have implanted would have had those same outcomes. So you touched on it already, John, the dry eye component. Yes, as we get older, things dry out. After we have cataract surgery, this is well documented too, that you may have dry eye. You may have subtle irregular surface irregularities on your eye. Your eyelids act to smooth that surface with your layer of tiers. Now, what's important is that the layer of tiers that you have is of high quality. The analogy I use, we're in Wisconsin, everybody plays hockey, or at least I don't play hockey. I'm terrible at hockey, but a lot of people play hockey. It's kind of like a Zamboni on an ice rink. If your cornea, after you've had surgery, it's kind of like you've played a whole period or two of hockey. It's all skated, it's all roughed up. Your friction is going to be really high. You're not going to skate very well. You're not going to skate fast. Your eyelids act like the Zamboni. And a Zamboni, if you know how that works, it's got to have hot water. That hot water smooths everything out. So we have our patients use a regimen of just basic artificial tears, preservative free, routinely, but a lot of times I have them on long-term anti-inflammatories, or I may use something called an amniotic membrane, or we may occlude your puncta. Your puncta is a little drain in your eyelid where we actually can plug that up, just like plugging a bathtub. Keeps your tears on the eye longer. These are all things meant to improve the quality of your tear film, to improve the functioning of your eyelid zambonis, if that makes sense. But it's all in a design to make those lenses that are now stacked together work optimally. Makes sense. I don't know if I lost you on that
No,
analogy.
you didn't. Okay, so to all of the people who dialed in who are south of the Mason-Dixon, who may not, who may not be hockey fans, I love the analogy, but it does, it rings true. I mean, the reality is that smooth surface is what creates the optical surface, and I say that only kidding now, knowing that actually Las Vegas has a hockey team, so it's who knew?
They're
Um,
everywhere, yeah.
yeah, they're everywhere. So from a practical standpoint, there's more than one component that contributes to quality of vision. So what can we say with with confidence that we have the ability now to optimize the visual system? We can't make you 20 years old like you may have never seen in your life without glasses, but if you were one of those individuals who didn't start wearing glasses until your 20s or 30s, and you remember having really great vision when you were 18, I can't make you 18 again. We can't do that. We can get pretty darn close though. And
Mhm.
this is one of those things where we can actually improve the quality of life. And especially for people who've had glasses all of their life, we can now make it better than they have any formed memory of. And the ability to take away of it. Patients one describe it to me as like this wet blanket that I just got used to. I had glasses and I couldn't. My first movement in the morning was to my nightstand for my glasses because I couldn't get around without them. Or this subliminal sense of dependency where I know that if I'm driving or if I'm in a strange city and my glasses break, I'm in trouble.
Mhm.
I can't drive. I can't function to the extent that I am dependent on this appliance. And you take that away, and all of a sudden it's like you don't think about it because you're so used to it, but you take that away, that dependence away. It's really liberating in a way that people who've never needed glasses just don't understand. But I hear it every day from people who did need glasses all their life, and they come back and they feel like, well, this has changed my life. I mean,
Yeah.
literally in a way that's so positive.
Yeah. So what we can't account for, I always tell patients this too. They always ask, is this going to last forever? And the truth is the lenses are designed to go into the ground with you. They're not coming out. We do this one time. So
That's good, Nick. That's good. Yeah.
they are. They're
Yeah,
wearable
time is
stuff.
undefeated. Okay, we'll go that.
Now, we can't account for any injuries. We can't account for subtle changes to the cornea. Things can happen. And am I going to tell you that it's not going to ever happen, that things aren't going to change? No, I can't promise that. However, I'd be surprised if they do. So I get asked point blank, often enough, have you ever taken one of these lenses out? And I can say, yeah, we have. I'm confident in saying that. Yes, we have. Have we taken out more of these compared to any other lens on the market? We have taken out far more multifocal lenses, far more depth of focus lenses than we have light adjustable lenses. And it's because of our confidence and the overall, at least as far as the overall average number of high satisfaction rates that we've got with this lens. We've taken out plenty more multifocal lenses than we have the light adjustable lens. Very, very few cases have we actually had to go back to the operating room. So again, I can't promise anything. Nobody can. And if you find a doctor that says, I promise, don't trust that doctor. There's no promise here. But what we're trying to do is play the odds and control all of the variables. So, what is the best way to choose a doctor and to choose the doctor who does the follow-ups? Does it matter if it's an OD versus an MD? That's a question I get all the time.
That is an excellent question. And I think that our practice is probably what a great example of what a team sport this is.
Mhm.
When you talk about, the surgical skill to put the implant in, this is something that physicians train for. We do surgical training. We do this on a regular basis, and that is a specific skill set. When we talk about the medical management that optometrists are trained to do, which is dramatic, there is so much skill, so much training, the ability to do an optical correction. If you want a great refractive correction, optometrists are the way to go. And for medical management of glaucoma and other things as well, the surgery is done by surgeons. But when we talk about what is the fundamental issue with the adjustments, it's a spot on, completely center of the target refraction. And Nick, you do an amazing job with this. I mean, there is no one better. And then even beyond that, it is the experience to know what patients will like. What is the likelihood that we're going to come up with a prescriptive correction based on experience that's going to optimize that individual's quality of life, and that comes from experience. And again, that is where the optometric side of this is such a huge plus. This is a procedure. A this is perfect for a team effort. And probably, it's almost like asking, okay, I had a knee replacement, but you know what? It wasn't my surgeon in the rehab clinic that strengthened my knee and
Mhm.
and got me back to 100%. It's like, well, no, there's physical and rehab doctors and medicine people who do that, and they do a really good job. And it's not the surgeon who got the knee put together, but now
Yeah.
that's not the end of the story. And so, should the medical doctor, the surgeon be doing the refractions? Yeah, of course, we're qualified to do that. We can. Quite honestly, I think the team approach in our practice has been so much of a benefit that I can't even imagine going back, because we've just had the ability to refine the outcomes in a way that I think would be difficult to reproduce any other way.
Yeah, there's definitely an art to this as much as there is a science. There's an art to the light adjustment process. A refraction is simple to do. It's the first thing we learn in school, but we're very well trained on it. It does come down to the experience of knowing which buttons to push, what dials to turn, and when to turn those dials and push those buttons. It's kind of like saying surgery is just as simple as taking lens out, putting lens in. There's an art to it, obviously. I'm not going to oversimplify it like that, but there's an art to both pieces of this puzzle. And I think the real team approach is kind of a beautiful thing, and we've really perfected that. And a lot of clinics work that way. And so I think it's really, important that you trust the team if you're looking for a team. RxSite actually has a clinic finder on their website that you can use and find who's in your area and
Mhm.
obviously do your homework. Make sure that you ask around and you trust that person. I think it really is important that you develop a relationship because I tell patients all the time, we're going to get to know each other pretty well during this process. I usually see them a little bit before surgery, at least have a phone call with them and then do all the adjustments. And that's 6 to 8 weeks of time where I'm seeing you every week. I joke with them that, hey, we're going to invite you to the Christmas party because you've been in the office so much. Make sure you understand that, that team is important and trust that team. But RxSite does have some tools that are available. So I think that's probably enough for tonight. We've gotten through our whole list of questions. We're going to do this again. We'll probably do this again in another month or two where we'll have more questions. Definitely interact with us. RxSite has or the Light Adjustable Lens has a Facebook page now where we encourage you to interact with us and submit questions there. As you're going through your own journey, things will pop up. We don't want to provide medical advice. Your unique scenario is individual to you as the patient. Make sure you go to your team first. However, if you have general questions or you just want opinions, we're happy to provide when we can. So, thank you, everybody. This is recorded. We will definitely send this to everybody and have a great night.
Thanks, everybody. Good evening.